The first case of COVID-19 was confirmed in China, and a year since the first Pfizer jab injection was administered in the UK. However, with the new coronavirus variant, Omicron, said to be detected in scores of countries, and cases rising rapidly in South Africa, have the sacrifices and innovations of the past 2 years been in vain, or could Omicron be the beginning of the end of COVID? Joining me now from Carlisle to discuss the potential impacts of this new mutation is Dr. John Campbell. John, thanks so much for coming on. You're a hero to millions of people, as you know full well, despite this modesty that you often always exhibit on the videos. You know, if people haven't seen the videos on your YouTube channel, they've got to see millions and millions of people all around the world. In fact, that's why I've got to ask you, why do you think your videos are that popular? What's wrong with so-called mainstream media coverage that they're not getting it from public service broadcasters or so on? Why do they need to watch expert in public health, in nursing and so on, to really understand what it means to their lives?
I must say that's been a bit of a mystery to me, Afshin. I actually started making videos way back in the early 90s on VHS tapes, and we used to send them to various places on the world. Then we went onto DVDs and used to send those around. Then we dematerialized online and YouTube. And it's just like taken off after the Omicron, not after the Omicron, after the COVID thing started. It just, the numbers greatly increased for some strange reason. I really don't know why it is. I think mainstream media are somewhat constrained in what they can say. I'm constrained as well. I have to qualify a lot of things. But I think the key thing is I try and give the evidence for everything. So obviously, I end up with a few opinions of my own, but I try as far as possible to go back to the experts, to go back to the papers, and just try and make it as evidence-based as I can. So it's just my best interpretation of the evidence that's around that day, really.
You don't think it's a regional accent as well? Usually we have Patrick Vallance, we have Oxbridge, private school educated people in the main, and there you are, you're using all sorts of data from internationally peer-reviewed papers and so on, and giving us and allowing the audience to figure it out to an extent what degrees of probability they should give to decisions they make about their own lives.
Yeah, I don't know how much accent's got anything to do with it. I think you need to be fairly clear, but yeah, it's. I think the mainstream media, in my view, actually underestimate the intelligence of the viewing public. It's not that people aren't intelligent, as mainstream media often might seem to almost indicate. It's just that they don't have particular expertise. I mean, if you were starting to chat away in you know, about your area of specialism, I'd be lost within minutes. It's just you know, if you can communicate it, put in the lower order concepts, put in the evidence, then people get it and people put two and two together. And then when they understand why something's important, they're much more likely to go with it. You know, you've got to carry people along with you rather than just, you know, it's very much do as I do, not do as I say. And these are my thought processes. These are what I'm pretty sure about. This is what I'm uncertain about. This is what I've no idea about. And being completely honest and upfront about that. You know, when I don't know, I'll say I don't know. When we're waiting for more data, we're waiting for more data. I think just trying to be as honest and open as possible with the people that are watching is the main thing. And of course, you have more time on mainstream media. Mainstream media is very sound bite-ish. You know, you get like 30 seconds chunk. And you know, to me, there's a lot more nuance to a lot of this kind of stuff and a lot more qualification. So the YouTube media is great because you can take that amount of time if people will stay and watch the channel that long, or they'll watch that video if they watch the video for that period of time.
Okay. I mean, I don't have any specialisms, but there's less nuance about two particular things. I'll get onto the food supplement in a second. Most particularly and specifically, and in a sense, what you just said there could be used as a reason of why there is a degree of vaccine hesitancy. If people don't believe they're being trusted by journalists, obviously. Just explain, I know, which you often do in many of the videos, and you have such experience, and you've offered the British government your services about training about vaccination on your on your videos. Do you believe that so-called anti-vaxxers may be spreading misinformation based on some studies that show heart problems because of vaccines, because of something that people are doing when giving the vaccinations? I know Britain has got the military out now to give vaccinations. Just explain what that is.
Yeah, absolutely. So with the adenovirus vector vaccines, we noticed that people were getting this blood clot problem. The Oxford AstraZeneca vaccine, for example, and the Janssen Johnson & Johnson vaccine. And they were getting blood clots in veins, and then a condition called thrombocytopenia, where there was a lack of platelets, a lack of clotting in the blood, combined with clotting in the wrong places. And then after some of the mRNA vaccines, the Pfizer and the Moderna, for example, people noticed there were some cases of heart inflammation, myocarditis.
Very rare,
and
I better say, quickly.
I was just going to say that, and thank you for that. It's incredibly rare. We are talking about a very, very small number of cases. But the question is, what is causing this? Now, there's quite a lot of research now that shows that this could be caused by giving these vaccines into a blood vessel instead of them giving them into the muscle. Now, the vaccine is supposed to go into the deltoid muscle there. Now, when I was 18 years old, I learned how to give injections, and we've been teaching student nurses this for the last 40 odd years. And what you do is, this is slightly bigger than the actual needle, but that you stick that into the muscle, and you can do that fairly quickly. That's pretty painless. Now, about 15 years ago, the World Health Organization said that you don't need to aspirate the injections. Now, what we always did was we stuck it in. Now, there's a possibility that the very tip of the needle there could, just through pure bad luck, end up in a blood vessel, because of course in living muscle you're going to have some blood vessels. So what we were always taught to do is just draw that back just a little bit, and then if there was blood in there, if you're actually in a blood vessel, you will get blood coming out, then you know not to inject it. It's a check to make sure you're not giving inadvertent intravascular administration. But the World Health Organization for pediatric injections about 15 years ago said, well, we don't need to do that. Now, that's probably true for the vaccines that we're giving to children. But then this advice seems to be taken from the World Health Organization, which was advice for vaccinating children. And that seems to have been extrapolated into vaccinating adults, which are different. And of course, with the new SARS coronavirus 2 vaccines, they're a different type of vaccine. So they're either the adenovirus vector vaccines, which have these virus-sized particles in them, or the mRNA vaccines also have virus-sized particles in them. So they are microparticulate vaccines. And if these particles get into the bloodstream, as I understand this science, then the body is going to recognize these as being viral particles and mount an inflammatory reaction as if they're viral particles. And that could be what's causing the inflammation. So all we need to do is tell people to inject, draw back before they squirt it in, and then inject it once you're certain they're in the muscle. Now, this is happening very rarely. This is probably only one in several thousand injections that this is happening. But it's a variable that it would be so easy to eliminate. So, for example,
Denmark is doing it. Our editor got the vaccination in central London. They wouldn't do that. No. I mean, what happens if there is blood when you pull back? Do you have to throw the thing away and have a new injection?
Well,
because that would cost more money.
That's right. But there again, you'd have less cases of pericarditis and less cases of thrombocytopenia, in my view, and you would massively enhance the vaccine program. Technically, what you should do, if you do hit blood, then you should take it out and basically chuck it away and get a new one. What you might do in a more challenged situation, if you got blood, you could just like withdraw the needle a little bit and still inject it, because it's only the person's own blood. You're not actually going to be doing them much harm. So it depends. If you're really short of vaccines, you might do that. But most policies would say that you chuck it out and get a new one.
Well, money
is a factor. Than giving it in the wrong place.
Money is a big factor, as we know. And from the beginning, your videos have often had a soft toy on the windowsill and a bottle or a jar labeled vitamin D. At no point, I mean, I have anecdotal evidence of NHS consultants telling me that vitamin D is given in hospitals. No point have I seen a government minister, one of the top chief scientific medical officers, talk about vitamin D, which is, compared to the profits of Big Pharma, what, $1,000 a second at the moment, no one makes much money of it. Why have you got a jar of vitamin D on your windowsill?
Yeah, vitamin D is essentially free. So normally we don't advise vitamin supplements, but there's actually two exceptions to that. The first one is vitamin D, because we make vitamin D from the sunshine. And if you looked out my window now, you wouldn't see a great deal of sunshine in the north of England. We don't get enough sunshine for at least 6 months of the year, probably nearer 8 months of the year, because we're actually too far north. We just don't get enough sunshine to make the vitamin D from our skin. And of course, human beings were originally in the Middle East and in Africa. We had dark-coloured skin, but there was lots of sunshine. So again, as darker-coloured skinned people moved further north, that's the reason we became white, because we could make vitamin D more quickly. So it's so important. So if you think about it, the reason that people have white-coloured skin is purely so they can make more vitamin D. And yet we're not getting the sun, so we're short of this vitamin. Now, it's actually more of a pro-hormone, really. It's turned into a hormone in the body. And there's vitamin D receptors in all of the immune cells, probably in virtually all the cells in the body, that the vitamin D is needed to facilitate certain particular reactions. And for at least 6 months of the year in the UK, we're not getting enough of it. Now, the government actually does recommend that pale-skinned people in the UK take vitamin D supplements all through winter. It actually recommends that darker-skinned people in the UK take vitamin D supplements all the year round. But the dose they're recommending, in my view, is just way too small. So if we went out in the sun and you take you're out in your shorts and, in a nice sunny day, you're probably going to make about 20,000 units of vitamin D. Whereas the government is recommending taking 400 units a day. The doses are very, very small. So we're just not getting this vitamin. And the other one that people can be short of is vitamin K2, because that comes from grass fermentation of the guts of animals.
Because the D needs to be taken with the K often.
Well,
people can watch your videos about it where you've talked about this, but as you say, the sound bites on going underground today. I've got to get on to Omicron. And,
go on to it.
And most disturbingly, usually very calm. As you say, billions are going to be infected by Omicron. Most alarmingly, you quoted Tim Spector saying PCR tests have a failure rate of 60% de facto, because you said they're only 30 to 40% effective. The WHO is saying accuracy of existing molecular tests appears uncompromised by COVID variant Omicron. People are being told to take tests left, right and centre, whether they need to travel, whether they need to go to jobs, and this is to do with this S gene dropout. I don't want to get into too much jargon with Omicron.
Yeah, that's right. So the PCR tests are phenomenally sensitive. If there's any viral fragments there of SARS coronavirus 2, the PCR test will pick that up. So it is still 100% working. But what happened was that the PCR test is testing for 3 genes. And the S gene that the PCR test for is not present in the Omicron variant. So if you've got the Delta variant, you'll test positive for the 3 genes. If you're positive for the Omicron variant, you'll only test positive for 2 genes. So this S gene dropout is being used as a proxy for the Omicron variant. Now, as well as that, of course, we are doing full genomic testing for the Omicron variant. So we know that this is collaborated. But what Tim Spector is saying is not saying there's any problem with the tests. There emphatically is not. The PCR tests are exquisitely sensitive. Many people would say far too sensitive. They're giving false positives or showing positivity for a long time after someone's got better. But what he's saying is that various brands or manufacturers of the PCR tests aren't picking up the Omicron variant. That's what he's saying.
And lateral flow, very quickly? Similarly.
The lateral flow will only show positivity if you have a fairly high viral load, and it will not tell you whether it's Delta or it will not tell you whether it's Omicron, no.
Dr. John Campbell, thank you.
Pleasure.
After the break, neither socialism